the patients are still in a recovery phase by the time they leave the hospital and they go to the nursing facilities. Developed a lot of relations with surgeons, skilled rehab, acute rehab, LTAC, etc. What we realized, or what I realized during my practice, is patients coming back into the hospital again and again, repetitive readmissions, the inefficiencies in our healthcare system that really fails our patients, the lack of access to healthcare, and the tremendous waste that occurs in our healthcare system. Why do I think that way? Well, I was raised in Denmark. We don't have the trillions of dollars that you guys deal with. We have a limited economy. It's socialized medicine. If we were to spend what you guys spend in a day in your emergency room, our entire country in Denmark would go bankrupt in a month. So, that being said, a lot of inefficiencies happen in our healthcare system. So my passion now has turned from, apart from just having a hospitalist group, I have a software company that develops medical software. We have a software that's specifically dedicated to surgical clearance. We have about 60 surgeons using that. Why did we develop that? Because we wanted a uniform standard, gold standard of how to clear patients for surgery. I always take the example of the airplane, okay? You're taking an airplane from here to Chicago. Imagine if every pilot started the airplane and took off whichever hell he wanted to do that day. Well, when it comes to your bodies and you want to go to surgery, guess what? Every doctor is doing it whichever way they feel like that day. There's no standardization of care. I would never get on that airplane if I had a choice. Patients, unfortunately, don't have a choice, and unfortunately, they are not knowledgeable about what is right or wrong because they trust their clinicians. So when I met Alex, who's my business partner in the IT company and the management company, I told Alex about my frustrations, and he said, first of all, let's standardize your office and get everything paperless and create efficiencies, and then let me pick your brain and take everything in your brain that you've accumulated for 17 years and create a software around it that helps clear patients with a proper risk stratification in an orderly format. And that's what we're doing. That's where surgeryclearance.com came in. We now have 60 surgeons using that, and we have engaged some very interesting prospective partners in that, UT Southwestern, THR, and hopefully by the end of this year we should be initiating the very first perioperative center in one of the facilities of these two companies. We are patenting the process of the clearance, and we are calling the whole concept Perioperative Centers of America. That's going to be our little child that is going to be the gold standard for medical clearance for surgical patients, and we want to take that nationwide. So that's part of what we do. The other part that we dealt with was when we discharge the patients home, why do they keep bouncing back? Well, it's because the first 7 days, and actually the first 48 hours after discharge, the most critical time when patients go home, they are either left alone or they're anxious. They go from an environment where there's 24/7 somebody around them that they can just call a button and somebody gets there, to an environment where there's nobody around, or the people that are around are not clinicians that have no clinical knowledge of how to take care of the patient. Medication failure, not to take the right medication at the right time with the right dose, is the number one cause of readmission. So, how do we fix that? Well, in healthcare, we're at least 10 to 15 years behind on technology. Having a technology-driven partner, I said, what can we do? Let's bring technology into healthcare and fix that issue. That's where I met with Nick and Fred and the Kate company, looked at their devices, which, you can go out and do a search on RPM devices and you'll find 1,000 companies out there that do RPM. Okay, so you have RPM and you're collecting data. You can have a whole pile of data this big, but if you don't take any action on it and there's no logic to what you're collecting, it's just a pile of crap. So what we did is we created an end-to-end solution, healthcare algorithms that go in and analyze the data. And I bring always Ms. Johnson as an example. Okay, you have a patient in the independent living facility who's has an activity tracker and a blood pressure medication, and a blood pressure measuring device, and she's going about her daily life. Well, what we can do now with the technology that we have, and if she's on the devices, which by the way are free of cost to her, all insurances cover them, doesn't cost the healthcare facilities anything. What happens with that is we can see, okay, Mrs. Johnson is walking less this week. She was more active up until now. What's going on? Blood pressure is becoming marginal as well. Well, that triggers in our system a call out to the patient in the facility. Let's send a nurse practitioner out, or at the very least, let's have a telehealth visit, see what's going on, get a chemistry panel, a CBC, urinalysis. We will catch that UTI at that moment before she even recognizes that she has a UTI, right? We treat her with $10 to $15 worth of ciprofloxacin for a week, and she's fine and she goes on. Well, what happens currently is not that. What happens currently is she develops urosepsis. Because she's older, she's not going to recognize all the signs as quickly and report them. Her balancing system is not as good. Her reflexes are slower. She's going to have a fall. She's going to go into renal failure. She may develop urosepsis. She may injure her head in the fall. Well, if she gets a hip fracture, guys, that's a 25% one-year mortality right there for a patient that age. That compounded with the healthcare cost, she goes to the ER, $40,000 easily spent that night, plus another stay in the ICU, and then on the floor. You all are paying for that through your tax dollars. Okay? We have less and less money to spend on more and more aging population. So my passion now has become create accessibility to healthcare, integrate technology in healthcare, and lower the cost of healthcare. And we can do that if we're smart and if we work together as a team to make that happen. It's not something that I can dream of. Me and Alice can create along with Nick, and it's done. No, it takes social worker, it takes the nurses, and it takes the physicians. It takes a society to understand the importance of doing that. People are going to Mars, right? And we're having to battle with people using EMRs. So I want for us to step back, be cognizant about our resources, and see what we can do to improve all those three things: accessibility, integrate technology, and lower the cost of healthcare. And that's how that whole care concept and our transitional care management concept came about. We have a concept where we take care of the patient for 30 days after their discharge. They get a call within 48 hours. We have a visit with a clinician within 7 to 14 days based on their acuity level. And then as many encounters after that as they need. With a touch of a button, they can get a hold of somebody instead of just being stranded and waiting on sister-in-law or daughter-in-law or son to take a break to take them somewhere. They have access immediately. And day 30, we bring them back to their PCP, make sure they have a scheduled appointment, and we're out of it. If there are certain patients that are in remote areas that don't have a PCP, we'll be happy to take care of those long-term, but the goal is to get them back to their primary care doctors. So that's in a nutshell what we wanted to bring to you guys. I would love to thank Good Shepherd for hosting and bringing this about. The reason why, you may ask, why is Good Shepherd and Dr. Lone and his team? Well, we have patients that require palliative care, that are not hospice patients yet, but require palliative care. This is an amazing tool for palliative care patients because they have access to us as a internal medicine urgent care type of clinic remotely on their devices, and we can help keep an eye on them, their oxygen saturation, their blood sugars, their what have you, through those devices. So hence that collaboration. I'm also an associate medical director for Good Shepherd, and we want to introduce that type of technology in the care of their patients, and they're really excited about it. So that's what I want to let everybody know.
Thank you very much.
Yeah.